Welcome to the webinar, Mastering Implant Restorations. This is part one of a two-part series, and this version is Where Aesthetics Meet Functions, Interior Implant Restorations. The main part of the lecture is being presented by Dr. Vivia Siqueira, BDS MS, and Tremaine Watkins, CDT, is here to assist with any lab support. And we will begin with the webinar shortly. And with that, it is my distinct honor to introduce our two speakers this evening. First up is Dr. Vivia Siqueira. She is the Clinical Assistant Professor in the Division of Prosthodontics, Department of Restorative Sciences at UNC Adams School of Dentistry. Dr. Siqueira began her academic career at Marquette University in Milwaukee, Wisconsin, where she taught prosthodontic courses in the predoctoral dental program. Her teaching and clinical work focuses on prosthodontic education and patient care, with an emphasis on integrating digital technologies into practice. She mentors predoctoral and graduate students, directs the removable prosthodontics course, and provides specialized prosthodontic care at the UNC Dental faculty practice. A former ACP John J. Sherry Research Competition finalist, her research interests include removable and implant prosthodontics with a particular focus on digital workflows and emerging technologies. And we also have Tremaine Watkins, CDT, Director of Strategic Education here at National Dentex Lab. Tremaine has been working in the dental laboratory industry for more than 35 years. He has extensive experience fabricating analog and digital prosthetics with experience in implant-supported and retained restorations. A respected lecturer on both laboratory and clinical aspects of restorative dentistry, Tremaine trains technicians and provides clinical support in case planning, troubleshooting, and implant placement. And now it is my pleasure to say, take it away.
Thank you. Thank you so much for the kind introduction, Jessica. And welcome, everyone. Thank you for spending this evening with me. I'm very excited about presenting this topic simply because I teach a lot of removable prosthodontics. I don't get to do a lot of implant prosthodontics with my students on the preclinical level. I do a lot of it with them on the clinic floor, but yes, I'm excited to talk about it. It's a fantastic topic, especially when you're starting out. And yeah, I hope to give you some tidbits and some clinical tips as we move along with implant restorations. For those who have probably logged in on the wrong webinar, I hope you stay on and you learn something at the end of this webinar. So without further ado, I'm going to get started. I have received an honorarium from NDX, but I don't have any other financial interests or any other affiliations with any organizations. And Tremaine Watkins also he's a full-time employee with NDX and has no other partnerships with any other corporate organizations. Again, we have not received any support, any commercial support otherwise. So starting today, we're starting off with the aesthetic zone. And I think what is important about this anterior maxilla region is that aesthetic outcome. It has to be predictable. It's a very difficult area to manage compared to most of the other quadrants in the oral cavity. And that's simply because you're working with soft tissue, you're working with hard tissue, you're also trying to match that pink and the white aesthetics as you are trying to get this outcome. So our goal is to try to have a very predictable outcome when we plan these cases, when we attempt and when we treat these cases, right? So comprehensive assessments are super important, and we're going to look at some predictable treatment planning sequences and strategies to help you achieve that. In order to do that, today we have a lot of digital implant planning tools, and we're going to look at some of that. The big thing that we're going to focus on is how to make a custom provisional implant restorations. We're going to look at that more in detail. And that is really going to help with that soft tissue maturation and soft tissue molding that you want with your aesthetic restorations. Again, we look at how our workflows can be more efficient, especially if you are including digital workflows in your practice or you've already invested in them. We'll touch base on restorative materials, and we'll also look at occlusal concepts related to implant restorations. So this is really the whole workflow in a nutshell, right? Like when you look at doing an implant restoration, you're starting from data acquisition, and that is not only just using an intraoral scanner, it may be even using the CBCT. So anywhere where you're collecting all that data, and now you're putting it into a CAD system in order to essentially either design or plan the implant or design a restoration and things like that. So with implant restorations, you have to first do a lot of digital implant planning. We don't do planning the old school way anymore. We have some amazing, very predictable digital tools, and we want to try to use that. Then is the show for the surgeon, because the surgeon's going to be placing the implant. If you are proficient with placing implants, then this is the part where all that planning is actually going to come to fruition. Once you place the implant, we're now looking at the restorative aspect. And that starts with an acquisition where you're collecting data on where the implant is located and try to get that impression. We then send it out to a CAD software where the restoration is designed, following all the principles that we need, taking into consideration all the aesthetic requirements. Then we are into the CAM aspect, which is the fabrication or the manufacturing aspect. And once that is done, you officially have your restoration ready for insertion. So in all of this, our patients can present at different points in time. Our goal is to know what our initial step one is, right? So what we first need to know is where are we starting? And what I mean by that. So your patients can present with different scenarios, right? You can have a situation where they've already come in with a tooth that is not restorable or there is a retained root, okay? Or you can have a situation where they're just completely edentulous, right? So there is a tooth that needs to be replaced. Or there is a situation now where they look like they're partially edentulous, and sorry, I meant partially edentulous earlier, but now it looks like it's just partially edentulous, right? But for all you know, there is actually an implant already placed in there and it's just sleeping in there, and we need to uncover it and restore it. And as you being the restorative dentist right now, it may fall on you to go ahead and restore it. So these are the different scenarios, but the first two scenarios, and even the third one to some extent, is going to have bits and pieces of these workflows that we are looking at, okay? So our initial focus is on the diagnosis and accurate records, because always remember with prosthodontics or just with restorative dentistry in general, as you go down the workflow, the more errors you have at the start of the workflow, it compounds and it cumulatively causes a major error at the end of it. So when things don't fit, down the line, you have to go back and see why that happened. And a lot of times it comes down to your initial records. So we want to plan correctly right from the get-go, and diagnosis and getting accurate records is super important for that. So we're going to do this like a case presentation, where I'm stopping in the middle. I will explain a few concepts that are related to that particular step, and we'll go along with this one particular case. So this patient presented to us with a retained root. She was a medical student, so you can see that there's a lot of generalized wear, and that's very spending a lot of time studying, right? A lot of stress that the patient was undergoing. So we have a few occlusal disease issues. We are having some oral diseases that we are looking at, in addition to the chief complaint that they want to go ahead and replace that tooth. Now, she lost the tooth due to trauma back in the day. It just broke off eventually. And there is an interim partial that she presented with, doesn't want to wear something removable anymore, and is ready to graduate and start her residency, and she just wanted to work on those teeth, on that particular tooth. So we had given her different options. Obviously, FPD was also an option, although you can see that the prognosis of an FPD might be lower because you also have a lateral incisor that's also going to be an abutment tooth that again does not have the best prognosis. So the implant restoration was something that she was specifically looking for. So we decided on doing that particular implant, right? So let's look at some more diagnostic records that we can collect about this patient. So here we have a natural smile. And this is a little tip that I usually, give my students as well. And this is an article from Dr. Bidra, is sometimes patients are shy because they're missing that front tooth and they don't want to really smile wide. And you'll never really know where that smile line is for them. Always have them close their eyes and smile, because sometimes when they do that, they actually smile wider and you're really able to see how much gingiva they actually display. Okay. So let's look at this smile line. When you look at these different smiles, right? The higher that smile line is, or the more gummy their smile is, your aesthetic outcome needs to be even more predictable, because their demand for aesthetics is obviously going to get higher. So if you look at the smile line classification, and this is a classic article by Tian, right? We look at a low smile line, an average smile line, and a high smile line. And what you see here on the left is a smile where you don't really see any of the gingiva, because the patient is just showing less than 75% of their anterior teeth. But as you start moving to the right, average smile lines, they will show almost the whole central incisor, and that is usually typical. Okay, so 75 to 100%. But when you see a high smile line, you're looking at greater than 100%. So these are the people that you're worried about. And that is actually my smile. So I am one of those tough patients if I had to be a patient. So let's look at this patient, because she is now a high smile line. She's like in that average high category. What did we look for when we started doing an aesthetic analysis? Because a smile line is just one of the many factors, right? So one is we wanted to look at that incisal edge position. Is that the position we want to replicate? And it looked like we had a very good aesthetic start point in terms of that incisal edge. When we look at the zenith position, because now we have to look at soft tissue as well, right? We're trying to replicate, we're trying to make things symmetric. You notice that zenith is slightly distal to the midline. When we look at that soft tissue contour, again, she's having a very nice symmetric contour. Now, I do see some recession, but overall, there is general symmetry. Okay. Embrasures also, they are regular in certain areas, but they're again irregular as you come along the anterior. And that's possibly because of an underlying periodontal condition. Again, axial inclination looks pretty good. The teeth are looking very well positioned and they're looking aligned. Now, the other important thing that we've noticed is the interdental papilla, right? The papilla is super important when you're planning your implant restorations. And we're already starting from a situation where the papilla are slightly blunted. And that's not great, because it's very difficult for us to actually regrow the papilla. And so we are already starting off with a probable black triangle, but we're going to see how we can mitigate that if that's even possible. Okay. We also got the tooth color, and we're looking at that restorative space. Now we feel that adequate restorative space exists for us to go ahead and do this implant restoration, right? So in terms of our diagnosis, it's a non-restorable tooth, retained root, obviously with number 9. There is secondary occlusal trauma related to that, right? Parafunctional habits exist, generalized bruxism. She had a few NCCLs, which are the non-carious lesions. Again, angle class 1 malocclusion. We did diagnose her with a generalized periodontitis. She was stage 3, grade B. There is recession, right? The great thing is that she has a thick phenotype. So that is aesthetically beneficial for us, because a thicker phenotype is more easier to manage. There are lower chances of further recession. There is more stability with a thick phenotype compared to a thin phenotype. So in terms of our treatment plan, Our systemic phase, we don't need to worry too much about that. The acute phase also, she doesn't have any major acute needs. What we're really looking at is our stage 3 and stage 4, where we are looking at first managing her periodontal condition, right? We want to stabilize her there. If there is some occlusal adjustments that need to be done because of the bruxism, we got to do some occlusal adjustments. And then we are starting to now plan for that implant that we want to do. Now, she's also mentioned that she wanted to do some bleaching, and that was a conversation that we were having with her then, right? We focused on getting all those direct restorations for the NCCLs, and along with that, we were also looking at doing that single implant and the restoration or the crown with number 9. At the end, we would also want to add an occlusal splint because A, she's got bruxism, and B is we also have a single implant in the anterior zone. We want to protect all of it. So the big question that now comes down to, in terms of when we're talking to our surgeons and we're trying to plan this case, trying to get those predictable outcomes, is there are so many ways to skin the cat, right? So how are we trying to place this implant? Are we extracting the tooth on the same day? Are we doing the surgery on the same day? How are we going about it? Okay. So there are some classifications that are classic classifications. Now, this was a case that actually my co-resident and I had done. This was one of the few cases that we had done in residency. And when we saw this case, we had just done a lot of literature review on implant protocols, and we were super pumped. We were like, yes, this is the case. This is that immediate implant placement case. And the reason why we said that was because the phenotype looked great. Her area looked really good in terms of the ridge defects and everything. So we didn't still have a CBCT, but we were pretty excited. But obviously, we knew that we had to do a CBCT in order to evaluate everything, right? But when we look at these protocols, right, when we talk about placement timings, implant placement timings, we're looking at the healing of the extraction site. And what I mean by that is if you decide to place the implant on the same day as the day of extraction, that's called as an immediate implant placement. Now, if you decide to wait for soft tissue healing, which roughly takes about 4 to 8 weeks, right, then you can do an early implant placement. Or an early implant placement is also when you're doing a partial bone healing has occurred, which is about 12 to 16 weeks, and then you place the implant at that time. And late implant placement is when you wait for a whole 6 months, wait for that area to heal completely, for the ridge to stabilize. Very minimal changes are going to happen from then on. And so you have greater control, and that's when you do your late implant placement. Now, the reason why I've started early implant placement is because with the kind of surfaces we have today with implants, the 6 to 8 week time is actually pretty good. So a lot of people do not wait for that late implant placement. They actually prefer doing it as an early implant placement, possibly after there is partial bone healing. So those are the times that we are looking at. A lot of people have realized that waiting for late implant placement, sometimes, especially in the aesthetic zone, already leads to a lot of remodeling, and you've already lost. If you started off with some papilla, you may lose that remaining soft tissue as well because the bone has receded considerably. So in terms of loading, now as a restorative dentist, we want to know when we can come in and when we can restore the implant, right? Now, when I talk about restoration, I'm also talking about the provisional phase. Basically, when can I attach a coronal piece on that implant, right? So, because if we try to do that while the implant is healing, then it's still getting some sort of occlusal forces can be subjected to it. So let's look at the different loading protocols. If you're looking at an immediate loading, what is happening is you're placing a provisional on the implant within a week of placing the implant. If you're doing an early loading protocol, you're basically placing a provisional somewhere between that 1 week and 2 months. Okay. And then if you're doing the conventional loading, that's when the implant usually takes around 6 to 8 months to heal. And that's when you are placing the restoration. But because the implant is already healed by then, which is greater than 2 months, you're essentially just doing the final restoration. Now, if you choose to do a provisional restoration at that time, it's only because you are trying to develop the aesthetics, or you're trying to mold the tissue before you place your final restoration. So in this case, we decided to do an immediate implant placement, and we decided to do a conventional loading. Now, we did not start off like that because we were super adventurous as residents. We wanted to do an immediate placement and an immediate loading, but we realized certain things that kind of like developed during the surgery, and we talk about that. Okay. If you are planning your treatment, these are some of the codes that you want to look for. Look at the codes for CBCT. There's a surgical guide code. If you are going to provide the surgical guide to the surgeon, then this is a code that you can complete. The implant code, if you're deciding to place the implant, then that's the implant code for you. Bone grafting codes vary. So I have just put one code in there. It really depends on how are you planning the graft. Sometimes you're just doing some bone graft at the time of implant placement, but otherwise you might be doing a guided bone regeneration procedure entirely separately, and then that is like a whole separate code that you need to add. Okay. If you decide to give them a provisional restoration, there is a code for provisional restorations. If you decide to give them an interim restoration, like an RPD, like an interim RPD or something, so then you have to code for that. And then when we look at abutments, you have either prefabricated abutments or the custom abutments. So the codes are accordingly. And then if you're doing an abutment level crown, what I mean by that is you have an abutment and then you have a crown. So that is called an abutment supported crown. So these are the codes based on the material that you use. And what I mean by that is that can be a metal or a ceramic crown. So those are the codes according to the materials. So like I was saying earlier, that we wanted to actually place it immediately, we wanted to load it immediately. So what really stopped us? And I think what really stopped us was that bone wall along the facial aspect. So whenever you want to do an immediate placement and an immediate loading, the case has a high success rate. Okay. But here's the catch: patient selection is super important. And it's a very specific situation when you can actually do this protocol and achieve success. And some of the requirements are that you need to have a intact socket wall. You cannot have a buccal wall that's fractured. You need to have a particular thickness of the wall. It needs to be at least a millimeter. You need to have that thick phenotype that we were talking about. You don't want any infection, especially no acute infection at the site. You need to have enough bone to actually anchor the implant. So good lingual, good apical bone. When you place the implant too, you want to have that really good primary stability. So you can actually measure that with the torque values, right? If you decide to do that immediate placement and immediate loading, you're basically placing your provisional restoration. And when you do that, you want to protect it from any occlusal forces. And so we're going to talk about occlusion on this provisional restoration. And obviously, at the end of it all, patient compliance is super, super important. If your patient is not willing to follow all those instructions, it's going to lead to a lot of forces while the implant is healing, and that can actually affect the healing of the implant, leading to possible surgical failure or early implant failure, right? And we don't really want those things especially in that anterior aesthetic zone. Going back to those alternative options that we were talking about, in the event that you cannot give them an immediate restoration, the patient can go home with a interim restoration. It can be an interim RPD, it can be a resin bonded bridge, or it can be the good old Essex. Now, doing a diagnostic wax up is going to help us with our implant planning, but it also provides us a tool to explain to the patient what the aesthetic outcome looks like. And now, if you look at this wax up, I've drawn some of the line angles, I've highlighted some of that. Those are the things that we wanted to mimic. But there were certain things, and I don't know if you can see my pointer, but there's some recession that has naturally occurred on this tooth to begin with. The other thing that we notice is that black triangle. So you see, if I try to mimic the tooth and make it extremely symmetric, I am already starting off with a black triangle. There is not much that we can do. And this is a nice conversation to have with the patient at the get-go so that the expectations are maintained. Our patient was completely okay with that. She understood that her periodontal status, and once she gets into the maintenance phase, there is a chance that there might be a little more recession, a little more clinical attachment loss, and we are probably going to see a little more of that black triangle. So, in terms of space requirements, when we talk about restorative space, and this is purely from the gum line right up till the incisal edge that we are expecting, especially for the anteriors, we're looking at a minimum of 7 millimeters space, which is mesiodistal or the horizontal width. And the reason why I'm saying that, especially along the gum line, we want that 7 millimeters because about 3 millimeter just goes in the space that we want around the implant because we want to maintain about 1.5 millimeters of bone on each side of the implant with the adjacent root, right? So we already don't have 3 millimeters that we can encroach on, and we need some space for the implant itself. So if you're using like a 4 millimeter diameter implant, then you're already starting off at that 7 millimeters, okay? For the vertical space, we're looking at about 5 to 9 millimeters, and that is because we're trying to fit all that componentry that we need while we restore this implant. And we're talking about abutments, we're talking about the crown. So those are all we need to maintain, and we need to accommodate the thickness and the integrity of these materials. So we first started with looking at that CBCT because we wanted to evaluate the bone volume. Remember, we wanted to do an immediate implant placement and an immediate load. So that was our goal. So we looked at the bone. Now, this is the part that is interesting because, yes, do we have lingual bone? We do. Do we have apical bone? We do. If we decide to place this implant, it will be anchored in native bone. But let's look at that buccal bone. Our buccal bone is compromised. We have about a millimeter here along the coronal aspect, but we don't have as much along that apical aspect. And so an immediate placement may be possible, but an immediate load may not be possible. And so we were like, okay, we'll take that. Let's try this. Let's go ahead with it. So now it was part of our implant surgery. We had to plan everything to get the implant placed in the most accurate position for us to predictably restore it. So let's look at our implant surgeries in general. Now, when you work with a surgeon or you're doing the surgery on your own, you're going to hear some of these terminologies, right? I placed the implant freehand. And what that really means is that there was no guidance. Okay, there was no physical surgical guide that was really utilized, or if it was used, then it was made in a very analog fashion, just like a pull down that was made on the cast, and you located what the central position is so that we can position the implant in the most axial location where the most appropriate axial loading of the implant would occur. So that is something that we did. We didn't really have bone volumes to go by because a lot of times people used panoramic radiographs then because CBCTs were not really available. So freehand surgery is still done. It's done in cases, or it's done in situations where you can predictably plan. You can look at the CBCT and you can decide. But if you want a more predictable outcome, you want to use a static guide, which is a CAD/CAM derived guide. So these are planned using digital implant planning software. Okay. And then the dynamic guidance is the more robotic guidance that we have using navigation systems. So you can have a very famous company as Yomi that actually has an robotic arm that uses CBCT to actually track the drill and place the implant in the most predictable or the planned position, taking into account bone volumes and where the restoration needs to be, because it is a restorative driven outcome. It's a crown down technique. So if we are doing a static, fully guided surgery, because a lot of labs do have access to digital implant planning software like Co-Diagnostics, 3Shape Implant Studio, what are the things that we can provide the lab? Okay, the very first thing is a CBCT needs to be done to evaluate the bone volume and quality. What we need to do as restorative dentists is take a scan, an intraoral scan or physical impressions, and we also need to provide a diagnostic wax up so that the lab knows where the final tooth position needs to be and then plan the implant accordingly. And if you see, they merge everything. So the bone volumes along with the tooth position and all the restorative, the final restorative outcome is all merged together in the digital implant planning software. And you can evaluate these. And the cool thing about these implant planning software is you can actually change the opacities of these different volumes, and you can see the layered restoration, the implant. It's super helpful when you're looking at it in three-dimensional slices. So this is, for example, a sagittal view of the implant that we planned. And you can see that we've anchored it in the bone. We're trying to maintain about 2 millimeters of bone along the facial aspect so that we have a more predictable outcome. We also want some bone along that lingual, along the apical, so that the implant can be anchored well. We've also put it at a certain depth, and usually we kind of place it a little subcrestally. But at the end, we definitely want it about 3 millimeters away from the CEJ, the planned CEJ and the free gingival margin. So here we had it placed about 4 millimeters, 4.3-ish. And you see it's coming. We want a screw retained restoration is what we planned. We didn't want to do a cement retained. And so we're looking at that access. It's basically coming from that lingual aspect, okay? So again, this would be an aesthetic restoration. And because we had a really nice amount of bone volume, we don't have to, our access is pretty straight. So that's also a good thing. Now we went ahead, we made our surgical guide, right? You can do that on those same software, and you can have the guides planned out and printed or milled. It depends on what the lab likes to use. If you don't have access to these, if you don't have license to these particular software, then remember to follow up with this digital case preview with the laboratory. So here's our surgical guide. We're ready for our implant placement. So you can see that where the extraction's done, the buccal bone levels were checked, okay? Here the surgical guide was tried in to be sure that everything is fitting. The implant is now placed, so the osteotomy is done, implant placement was done. We took an x-ray to verify the position. Because we decided to do a conventional loading, now we're going to be following this up. So you can see that we followed it up. The tissue is healed really well around that healing abutment. And so we have a follow-up of 2 months, which looks great. Now, if you want to make a provisional at this point, right, you can use multiple techniques. The direct technique is if you're doing it intraorally in the mouth. So in this case, you can use a provisional crown with little wings on it to stabilize it as you connect it to the implant, or you can use a more an Essex or a pull down, which can sit on rigid teeth, and you can get that stability as you do the provisional fabrication. And if you don't want to do it in that fashion, you can go ahead and just take a quick impression of the implant, right, using a regular analog, and pour up the cast. And then using this external surface form of a pull down, you're going to go ahead and how you make like an Essex, you're essentially going to load it with Flowbill composite, and you're going to pick up, or bisacryl, and you're going to pick up this particular implant location. And in order to do that, we have temporary cylinders available. They're either made of titanium or they're made of PEEK. And so you can see here how we have actually sectioned off that cylinder and altered it so that it can fit into this external form. And because we've made that little hole so we can access the screw at the end of it all, right? So now we have important things that we need to look for in our provisional restoration. One is the proximal contacts. We need to have smooth abutment crown and a face. We need to look for ideal emergence profile, and we're going to talk a little about that. But the most important thing is think of it as a party tooth. We do not want to have any occlusal contacts on this provisional crown for now. So no centric and no excursive contacts while the implant is essentially still healing. So when we look at our emergence profile, okay, our emergence profile needs to either be concave, it needs to be a little on the flatter side, not convex, okay, and the flare should be less than 30 degrees, okay. If it is more than 30 degrees, it becomes really shallow. And that again affects the off-axis loading of this particular implants. So in this case, if you see, we either have slight concavity or we're having like a straight emergence. And the reason why the emergence needs to be carefully looked at is because if your emergence is over contoured or it is bulky, it can actually cause recession of the restoration of the gingiva, and that can affect your aesthetic outcome. So you see, we've got these nice concave contours along the lingual, along the on the buccal as well, and a little more flatter along the mesial and the distal. And so this is our provisional restoration that was ready to be inserted in the patient's mouth. Again, like I said, that we don't want any occlusal forces on this for now. So it's a protective occlusal scheme. When we torque the screw, the abutment screw for the implant, there are a couple of things that you want to pay attention to, where you want to hold the driver head right here while you're stabilizing the torque wrench, and see to it that the arrow faces you if you're trying to tighten the screw, but always hold your finger onto this section of the torque wrench and not along the main handle right here, because that will not is not going to help the situation. You want to be able to torque this, and you want to be able to see the torque at which you're applying onto this particular screw. So this will give you a false reading, or it may actually not help you at all. Okay, practice how to use a torque wrench, and only start torquing when you have engaged. You can have a tactile sensation that you've engaged the screw. So this is us with a provisional restoration. You can see that at baseline, we have the gingiva is still in that receded position, and that it's like a skinny emergence profile. We're now developing that. We're adding, the patient comes in every 2 weeks. We remove this restoration. We add a little more flowable composite. We start creating some pressure along the gingiva, again, maintaining those concave emergence. And over time, because we've applied that pressure, we've kept those concavities in certain areas, the gingiva starts creeping down, and we eventually actually gain some of that gingival aesthetic that we actually wanted, which is good. So we're pretty happy with this molding of the gingiva. We now wanted to go ahead. We were like happy with it. The patient wanted to move forward as well. So we decided to finalize our implant crown. So here we're taking an open tray impression coping, and what I mean, an open tray impression, and what I mean by that is we're using an open tray impression coping. So this needs to be, the best rule that I always remember is locate or vacate. And what I mean by that is when you place this coping in on the implant, right? When you remove that impression, you're not going to be able to just take the tray off, because this coping is screwed in and it peeks out through your impression tray. So you want to actually unscrew the coping first, and then when you retrieve the impression, the coping comes along with that impression. What we also did is we customized this particular impression coping, because we wanted to use that, all the molding that we did, we wanted to capture all of that. So one of the ways we can capture that is by customizing our impression coping. So the way we did that is we removed a provisional crown, okay, and we placed an implant analog, and we first secured that in stone. And then we just went ahead and added a little of the bite registration material all around the base of this crown. Once that was done and set, we removed the crown out of this area. And now we placed our impression coping in there, and we just added a little flowable in that gap so that it copies that emergence profile. So now when we seated our impression coping on the implant, it supported the tissue the exact same way like how our provisional was supporting it. And we were able to take that impression, very easy to just record the tissue where it is. Now, these are a few things that you want to pay attention to when you place your impression copings. Check and see if your impression copings are seated. So you can see on the far left that it is seated completely. If it is not, you might notice a little gap along the implant and the coping interface. If it is not seated, you may want to see what is interfering, or unscrew it and again seat it, and see to it that you can feel tactile sensation that it's seated. With digital impressions, scan bodies are what are typically used. They're basically scannable impression copings. The problem is that they are manufactured with a variety of different materials. So sometimes they are visible along the radiograph, or sometimes only the metallic components are visible. So sometimes it might be difficult for you to see the complete seating of these impression copings, but they're used very often in practice now. When you're doing your final impression, you want to capture, and this applies to conventional as well as digital techniques, you want to capture the proximal surfaces of adjacent teeth, the occlusal surfaces, obviously, of the adjacent and the opposing. The most important is also the peri-implant tissue cuff and your interocclusal record. Now, when you're doing this digitally, there are different ways of doing it, okay? If you do it in the more traditional way, which is inbuilt with most of the implant workflows on your intraoral scanner, you're basically going to capture the pre-scan essentially with the tooth in position there. So this gives the lab information of how the tooth actually needs to look like. The next thing you're going to capture is that soft tissue cuff. Now, this is where it gets a little tricky because you have only 10 seconds to scan before that tissue starts collapsing after you remove the healing abutment. So you have to be quick about it, and especially if you've done all the work in molding that area. And then last of all, you need to give the lab where the location of that implant is going to be using this particular scan body, which is an impression coping, technically a digital impression coping. Now, if you are doing it in another technique, which is also pretty easy because you can see that the tissue can collapse. So instead of scanning the soft tissue cuff, what you can do is once you've scanned the provisional in the mouth, you can go ahead and just scan the entire provisional, because the lab can essentially align all these scans together and can tell. The lab now has a master model or a master scan essentially, knowing what that cuff looks like, and it hasn't collapsed on you. So this is a more preferable technique. You literally have to just scan it outside the mouth, okay, the provisional. The next thing what we want is to use our shade guides. So when we look at our classic guide, we all know that it is a hue based guide, and it does not, and value is super important when that needs to be taken into consideration. So we do have a 3D master shade guide that is a little more specific with the way you can capture shade. And the way you see it is you'll probably see a shade tab that will read as 3R2.5. And what that means is the 3 actually stands for chroma. So this is a value-based guide. Okay, so what we're starting off is whether we are in that, sorry, the 3 stands for value. So you can see here originally you start from 0, 1, 2, and then you go all the way to 5, which is a value-based guide. And then we look at the R. The R is more of a hue-based color. So you can either have an L, M, or R. R is more reddish, L is more yellowish in terms of hue, right? And then the 2.5 is essentially the chroma. So you can have a very low chroma at 1, or you can go all the way to a very high intensity where we're looking at something at 3. Okay, so based on that, you can really divide that. You can really figure out a shade tab that closely matches the tooth. Now, if you don't have one shade tab, you can even have multiple shade tabs that you use, but positioning the shade tab is also crucial because contrast effects are very rare. So whenever you position your shade tab, always position it on the same side of the tooth and also in the same plane as the tooth. And the next most important thing is also when you capture your shade tab, also capture the tab so that the lab knows which tab you are referring to if you have multiple tabs. Okay, so you can see that this is a shade map that we created because we wanted to create a more aesthetic looking restoration. And there are different ways you can communicate this. This is one way you can use shade communication. This is the seating of our final restoration. And again, we've taken an X-ray to see that it's completely seated. So in terms of crown material selection, We can either have zirconia, we can have PFM, or we can have a gold restoration, or we do a lithium disilicate or a lithium silicate restoration. Zirconia is now very popular when you are doing an anterior restoration, a lot of ceramics. PFM is also done pretty frequently, and if you're doing zirconia, it's more of a 4Y maybe, or even a 5Y. Again, specify the moles when you are asking for zirconia. 3Y is more opaque, and 4 and 5 are more translucent and more aesthetic. But the more you improve the translucency, you are going to sacrifice strength. And this is like a good diagram to see that zirconia is actually pretty strong. But if your moles are actually more towards 3Y, then you have more strength and you have less translucency. But again, if you look at it in an aesthetic way, glass ceramics are still more aesthetic than zirconia. Now your crown can be of different types. The most common that we talk about is either a one-piece screw retained crown. And what I mean by one piece is that it's the abutment and the crown are all just one unit. And then there would be a screw that kind of goes through that screw axis. In a screw-mentable crown, it's still going to be a screw retained, but the lab will provide you an abutment and a crown separate and the screw, because you are going to place that abutment, you're going to try the crown in just like you would try a natural tooth crown. And if you like how the crown fits, then you take the abutment out, you cement it outside, and then now it becomes a screw retained restoration that you screw in. And then you have a cement retained restoration that is essentially cemented onto the abutment. Now, cementing something intraorally can get tricky because, especially around implants, if you have any residual cement, there is a high risk of peri-implantitis, which is a very big problem with implants, and we want to find ways to curb that. In terms of abutment selection, we were talking about prefabricated abutments, so stock abutments, right? Or we can look at more custom abutments. And the custom abutments typically you'll hear about are UCLA abutments or abutments that are CAD-CAMmed. Basically, they're digitally fabricated. And then you have this hybrid abutment that lets you do a digital workflow, but using a titanium base. And what I mean by that is, first let's look at how our abutment is designed. So here you see that our crown seats on this particular abutment that is screwed into the implant crown. And then you'll usually have an interface. So this is more of a customized situation where you have a good height for the abutment so that the crown has good resistance form and it's supported really well. These were also casted back then. So you can see that sometimes you can just have a solid stock abutment. So if you're going from the left to the right, and this is really like a transition, if you're having a solid stock abutment and you're cementing a crown on this, then you place the abutment in there, take an impression at the abutment level, and get the crown seated. Then we have the UCLA abutment. This was the abutment that was used more often, where we actually waxed up a crown or an abutment and the crown entirely on it. But what is more important is throughout what you have these metallic connections that go and seat into an implant, because metal on metal is great in terms of wear. And then we see the CAD-CAM abutments that are used now. So initially we used to have just titanium, and then we had titanium with a gold hue because we realized that having a gold hue along that emergence profile gave a more aesthetic pleasing appearance. So now we frequently prefer a custom abutment compared to a stock abutment because we can actually replicate that emergence profile, and we want to have aesthetic outcomes in the anterior zone. So you can still do a UCLA, or you can do the digital versions, which is your custom abutments. And Tremaine, do you want to go over when would you actually use a UCLA instead of a CAD-CAM abutment?
Absolutely. So some labs are still hand fabricating. Dr. Kara was giving me a hard time about this. She's, yeah, when you were young and dinosaurs ruled the earth, all the abutments were made that way. And that's kind of true. But the thing is, even with a lot of the screw retained crowns that you get from your laboratory, there's cement in them. We've cemented them and we use the same kind of cement you guys do. And obviously, we have the advantage of using a big curing box and different things like that to get a good cure on it. but there is a possibility of them separating. So let's say you have a second molar and not a lot of occlusal clearance, patient has potentially parafunction. You could make a gold crown, a screw retained gold crown using a UCLA, and then of course the gold crown part of it's indestructible. And since the two components are cast together, it can't delaminate, because what happens is that we actually wax to this little plastic cylinder here, and when we cast it, the metal flows around that you can't see, but there's little ribs in the thing that looks like a tie base, and the two are essentially bonded together. So that can be really good. The other thing is there are limits to what can be done with a custom abutment. In other words, angular correction and different things like that. So if you have a case that hopefully you weren't involved in the planning on, where the implant is, especially in the aesthetic zone, buccal, angled buccal, sometimes you need to use a UCLA abutment just to create something, so that I've done cases before where we have to have a screw hole essentially in a gingival simulated area that's pink, and then we basically use the UCLA to build the post lingual to the entire screw access, so that way the crown is in the correct position, and then we're making a gingival simulation. So those are a couple of examples of when you might want to use UCLA even today.
Yeah. Coming back to what we were saying about having that restorative space of 5 to 7 millimeters, when you're starting to get really tight, that's when you can consider, because delamination can be a problem, and especially when you have multiple interfaces, the risk of delamination kind of increases. So UCLAs are like casted as to one whole unit. So then you're reducing the number of interfaces. So you have to start getting creative when you are in a more compromising situation. But when you talk about tie bases, I think where we started looking at how zirconia or ceramic was very tissue loving. And we wanted to know that, okay, from that titanium hue, can we start using ceramics in order to get that really nice emergence profile? But the problem is, initially, when they did it as a complete abutment that was made entirely out of ceramic, even the part that goes and connects into the implant, we would see that micro motion would cause fractures. Sometimes the abutment fractured, but sometimes it would actually affect, or it would abrade the implant, and so the implant's not usable anymore. We don't want to be in that situation, so we switched back. We started using tie bases, and tie bases are great because they do have an implant, the metal component that goes into the implant, and then you can see this vertical component or the chamber that is going to at least attach the crown. Now, there are two ways of doing that in terms of the emergence profile that you wanted in ceramics. You can either have like this meso abutment or this middle section. That can be a separate section. So you're now introducing another interface, and you have a crown that attaches to that meso abutment, and then the meso abutment essentially screws onto the tie base. Or you can have the entire emergence profile as this massive crown that just goes and cements onto the tie base. We noticed initially when tie bases were introduced that they were again fracturing, just because the chamber used to be so tiny. It was like a tomato on a stick situation. And so now we start having a lot of tie bases that have different gingival heights as well as different chamber heights to give some more retention while we create that interface for bonding in terms of retention and resistance. But this is the final outcome. So all that hard labor that we did led to us maintaining that gingival position even in our final restoration. You can see that there was some recession on the contralateral tooth, and that is why our implant crown looks a little longer. The patient did not want to address number 8, and so we just kind of maintained it. I think we got a very good outcome in general. When we are looking at occlusal concepts now related to the final restoration, obviously the patient has invested in the tooth. They do want to have centric contacts, right? We do want to load the implant, but we want to have light centric contacts on the implant. And what I mean by that is, if you ever have a shim stock film, which is about 8 microns in thickness, right? What I always tell my students is that look for a single shim stock will essentially slide, whereas a double shim stock will hold when the patient bites down. So you are usually, especially in partially edentulous cases, you're restoring to their actual original occlusal scheme, which might be just an MIP, sort of maximum intercuspation. You're not really going into CR if they're not in CR, right? So when you're just adding a tooth, maintain light centric contacts on there and avoid excursive contacts. If you really have to have excursive contacts, like in this case, it is an anterior tooth, there is going to be some protrusive movement, then either try to have a light protrusive contact on there or try to avoid it if their mandibular movement allows you to get away with it. So let the natural teeth take the load most of the time, especially in excursives, because it has the protective PDL that implants don't have. And that is the biggest problem with peri-implantitis that we see around implants that are secondary to occlusal loading when occlusal forces are not controlled on that implant. Going back to what Tremaine said about trying to get creative with your abutments, sometimes you cannot. The bone does not allow you to place the implant where you want it and in where you really want a nice aesthetic outcome. You have different ways to correct the angle. The labs will frequently use an angle screw channel and give you a driver that's specific for the screw that goes into an angle screw channel. You can also use a multi-unit abutment to change that angulation. Some implants are designed to have an angulated head to it already, which helps control that. And then if not, if you just have to go for a cement retained restoration and you can control that residual cement, then cement retained restorations are a possible option. Now, going back to that third situation that I was talking about, what if a patient actually walks in with an existing implant? Right? Sometimes you will see something like that. You'll see a little metal peeking out of their mouth, and you're not sure what this is. Always, when you are not sure, take an x-ray. Okay, one is the healing abutment can be what is peeking out, and ideally the healing abutment is a transmucosal abutment. What I mean by that is that it needs to peek out of the soft tissue. That's normal. That is a healing abutment. That means your implant is it's placed at an adequate depth, probably. Okay, the next situation that you can have is a cover screw that is essentially placed on an implant. Now you see the cover screw is really short. It does not have that chamber height that the healing abutment has. And ideally, if your implant is placed in an ideal subcrestal location right here, then the cover screw is actually at the bone level. The tissue is right here. So you shouldn't be seeing a cover screw. If you see a cover screw, that means your implant is not positioned at the best spot. You may want to reconsider if you want to be the restorative dentist on this. And again, if in the best scenario, the implant is in the best location, the problem now is you want to start getting all this componentry to restore it, but you don't know what implant that is. And we actually have a site that is, thanks to Dr. Howell and Dr. Farley, we actually have a site that says, what implant is that? You can put in all the details about the implants, and it really helps you walk through it. There are all these little drop-down menus, and you can describe the macro features of the implant. And once that is done, and with an x-ray, comparing it with an x-ray, you'll be able to identify whether it is an implant of a popular brand. These consultations can also be paid. Otherwise, it's a free website. So if you're not sure how to fill this out, you can seek for a consultation as well. If you're not sure, if you're still not absolutely sure, take some photographs of that internal connection or whatever connection. You have an external connection for an implant. Take some x-rays. If you can see any healing abutment or something on there, sometimes take just photographs even of that, because they're usually color coded. You'll be able to see the portion that grabs onto the screw head, and you'll be able to see that. You might be able to identify it with those particular colors, at least the more popular brands. Yes, Tremaine?
I was going to say a couple other things that can help with this is test it with your screwdrivers. If you know what kind of driver it uses, that really helps narrow it down. And if there is something like a healing abutment projecting through the tissue, you can do a quick scan with your scanner, because then we can use those dimensions to help figure it out. In the laboratory, we get a fair amount of these. And in my company, I often wind up on the short end of this particular thing. So I've developed a whole little protocol. So the more data you can give me, the better my detective work is.
Yeah, so you essentially have to have a driver kit that has multiple drivers in there. But also, what I would say is that always rely on a tactile sensation. If you can't feel it engage, then don't force it. Because if you strip it internally, like if you strip the screw head, then it's very difficult to actually now restore it. And that makes it hard for any restorative dentist in general. But yeah, this is really a nutshell of everything. I hope the presentation that we've provided helps you gain some confidence to attempt an anterior implant restoration. This is just my team, our wonderful team. We have wonderful colleagues at UNC. We've got some wonderful dental students. We recently had a graduate prosthodontic cohort. They just graduated. There's beautiful pictures with their fancy certificates, all going to be wonderful prosthodontists all over the country that we're very proud of. But yeah, my contact information is down below. Please scan the QR code, and you can always reach out to me if you want to out of this presentation as well.